Start today's lecture, and today's lecture is on diabetic retinopathy, classification and management. Yesterday we did the pathogenesis of diabetic retinopathy. Today now we'll go in and do the classification and the management of each component once you classify. Diabetic retinopathy classifications. There are two classifications which exist. One is called descriptive, which gives you background diabetic retinopathy, or when people are writing, they just say DR, diabetic retinopathy background. Then you have got diabetic maculopathy, where the macula is affected. And you've got macula affected, diffuse retinal edema. You have focal retinal edema. You have ischemic macular edema, which we talked about yesterday when we looked at the macula. The next classification is the pre-proliferative diabetic retinopathy. That stage before the formation of new blood vessels occurs is referred to as pre-proliferative diabetic retinopathy. And once the blood vessels occur, the classification changes to proliferative. There is a proliferation of blood, there is a growth of blood vessels. So it comes at proliferative diabetic retinopathy. Then lastly, you have the advanced diabetic eye disease, where more and more complications are occurring on the retina. For example, you can have significant persistent vitreous hemorrhage, tractional retinal detachment, or formation of new vessels all over the retina. This early treatment diabetic retinopathy study classification, which we'll look at later properly. Is this the one? The next one, isn't it? Background from here. This is the first part. So we're now going into a bit more details to look at the background diabetic retinopathy. What is there? You've got small aneurysms. How do the aneurysms form? I think I explained, where there is ballooning of the endothelial layer of the small capillaries. Those are the microaneurysms, localized outpoaching from the capillaries. Mainly circular pericytes are absent and develops in the inner capillary plexus, inner nuclear layer of the retina. These are what they refer to also as microaneurysm, those ballooning of portions of the capillaries. So microaneurysms are formed from outpoaching of capillary walls, which may leak plasma constituency into the retina as a result of breakdown in the blood-retinal barrier. I think you've heard my explanation exactly what I was telling. Features, they appear as tiny red dots, because if they are outpoaching, then the endothelial part of the capillary is where the blood is moving. So if there is any outpoaching, some of the blood now sits in that outpoaching. So when you are looking through the retina, when you are doing your fundoscopy, these appear as small red dots. They appear as red dots when you are looking into the fundus. And mainly, initially, these are temporal to the fovea. And on fluorescein angiography, these dots, they show hyperfluorescence dots due to leakage. What does that mean? Fluorescein is injected intravenous or intravenously it circulates through. So where there are outpouchings of a capillary or whatever blood, there is more staining because it is stationary there. You find them as dots of the fluorescence. So you have this fluorescent hyperfluorescence of the dots, because now the fluorescence which has come with blood, some of it ends in those small outpouchings from the capillaries. So when you are looking there, you see them as small dots. Location of the lesions in diabetic retinopathy. This is a cross section of the retina. This is the inside, this is the outside here. There, outside, inside of the retina, of the eyeball. Obviously, inside, you've got the internal limiting membrane, you've got the nuclear fiber layer, then you come to all these layers which contain the blood vessels. Okay? Then outward here, you have the cystoid spaces. Then another layer there, and you're out there. This is a cross section of the retina. So for the eyeball, you would have the whole thing completely round. Yeah. The stalk of the eyeball is the optic nerve, where it comes out, the fibers of the optic nerve, where they come out. Okay, that's it's a stalk on an eyeball like that. The stalk is the optic nerve. Retinal hemorrhages, retinal nerve fiber layer hemorrhages arise from the superficial precapillary arterioles. Look, the ones which are out here. These, when they break, you have bleeding in the superficial layer. This is the superficial layers. When you are looking into the eye, this is the first layer you see. So if there are hemorrhages here which are clearly on the nerve fiber layer, they are superficial layers in relation to the retina. Because this retina thickness goes all around to form the eyeball. So retinal nerve fiber layer hemorrhages arise from the superficial precapillary arterioles. Okay? The intraretinal hemorrhages. Intraretinal, these are the intraretinal, inside the actual retina. These are intraretinal hemorrhages. These red stuff. They are within the retina. The superficial ones will be in the nerve fiber layer. Okay. Retinal nerve fiber layer. What is the other one? Intraretinal hemorrhages arise from the venous end of capillaries. This is the lecture. These are found in the compact middle layer of the retina, appear as dots and hemorrhages. In other words, these which are in the middle layer, they don't have the chance to spread. They are sort of compacted. They appear like dots when you are looking into the eye. They are in there. Those that are in the nerve fiber layer, they have chance to spread. So they look like a sheet of, blood which has fallen there. And the deeper dark round hemorrhages, those found in the compact middle layers, they appear as dot and blot. Then you've got these deeper round, dark round hemorrhages. In fact, when you are looking into an eye, the darker the darker they appear, it means they are deep into the retina layers. If they are superficially, they will be more red. As they go deep, they appear more dark. So deeper dark round hemorrhages. These are hemorrhagic retinal infarcts and located in the middle retinal area. So I think it's the concept of this that will show you. The left fiber layer to be more bright. As you go deep, they become round and round like that. You know? These cystoid spaces, this is also a combination of fluid coming from the retinal capillaries to form fluid spaces, which they refer to as cystoid spaces. Okay. Any questions, please don't hesitate. Keep asking so that we end together. Because when you wait for the lecture to finish, you would have forgotten what you wanted to ask. It's better you ask now. I slowly explain to you, then we proceed further. Retinal microaneurysms. You can see these two pictures. This is a direct picture into the eyeball inside. This is a fluorescein angiography picture. After injecting the fluorescein, that fluorescein travels together with the blood. And when you take a picture, there is hyperfluorescence, and this shows where the fluorescein has gone, where the blood is going. So this is same picture, except this one is fluorescein angiography. This one is a direct picture where when you do, for example, fundoscopy, you can see this is the macular area, fovea area. Fluorescein outlines the blood vessels properly, and you can see if there is any leakage from a blood vessel, it will show. You know, because sometimes people can have edema here. You find it's a leakage from a blood vessel. How do you work out? Sometimes you have to do fluorescein. You find from there fluorescein is leaking coming there. Diabetic retinopathy, deep and blood hemorrhages. You can see they are looking compact, round. They are not spreading like that. These are deep hemorrhages. I'm sure we'll have one picture for superficial hemorrhages. It's not the next one. No, deep also, and the blood hemorrhages. This. They look compact, round like that. Superficial ones, they spread away like that. I'm sure they have a picture somewhere. We'll get one. Okay. Exudates. Exudates, these are, what are exudates? Anyone with an idea what are exudates before I anyway, they are already reading there. These are caused by chronically localized retinal edema. Okay. Develop at the junction of the normal and the edematous retina, composed of lipoprotein and lipid filled with macrophages. These are the exudates in the retina, located in the outer plexiform layer. Features. These exudates appear yellowish. They are yellowish lesions with distinct margins, usually arranged in rings. The center of the ring, that's the point of leakage, where the leakage is occurring. Then as it's getting out, going outward, you find the rings forming of these exudates, yellowish stuff around. With time and the number and size of exudates tend to increase, obviously. If there is continuous leakage, slowly the exudates will increase. You know, over months, over years, usually with phagocytosis of the lipid content by the other cells. Chronic leakage leads to enlargement of the exudates and deposition of cholesterol. Fluorescein angiography. There is hypofluorescence due to blockage of background choroidal and the retinal capillary fluorescence. What happens is this. These leakages, these are appearing on the surface of the retina. Now, the yellowish stuff block light. You can't see the fluorescence in the vessels below those exudates. They block that. This is what they're saying. Fluorescence shows hypofluorescence because there is reduced fluorescence in the exudates due to blockage of the background choroidal and retinal capillaries fluorescence. Macular edema, diabetic macular edema. Diabetic maculopathy can be foveal edema, can be exudates, or can be ischemic. In the most common cause of, and is the most common cause of visual impairment in diabetic patients. So diabetic macular edema, you can have edema, foveal edema, exudates can occur, the yellowish stuff we're talking about, can be at the fovea, it will affect vision, or it can be due to the last one here. Which one? Ischemia. It means blood vessels is not reaching the macular area. There's a blockage somewhere. The blood is not reaching there. Yeah. Diffuse retinal edema is caused by extensive capillary leakage and localized edema by focal leakage from the microaneurysms. Okay? You remember we talked about microaneurysms yesterday, where there's a weakness in the wall of the blood vessel, and there's outpouching. Those are the small microaneurysms of the vessels we're talking about. Leakage can occur from those. With further accumulation of fluid, the fovea assumes a cystoid appearance. You have fluid deposits around because you've got now leakages from the capillaries there. Retinal thickening is best detected by slit lamp with a contact lens. Okay. Fluorescein angiography shows diffuse late hyperfluorescence due to retinal capillary leakage. The fluorescein will come together with it's already injected in the blood, so it will come together as the circulation continues. You know. No questions so far. Huh? Oh, okay. Meeting ending very soon. No, it's a small break.
Yeah.
We're not ending until we finish this topic. Still 38 to go.
On features.
Diabetic macular edema. I think what you as students or any ophthalmologist should be aware of is the poor vision in diabetic retinopathy can be due to edema, can be due to exudates, can be due to ischemia, where the blood, the capillaries are not supplying the macular area properly. All those three are features which you find in diabetic retinopathy.